So welcome everyone. In my presentation, I would like to introduce the current state of our two projects. My name is Kinga Kovács, and currently I'm a second-year pediatric resident. Our vision is that the focus in neonatal care should be on eliminating as many complications of prematurity as possible. That's why our mission is to investigate perinatal risk factors. To achieve these aims, here are our specific goals, our specific projects. One is related with the histopathology of the placenta and the umbilical cord, and the other one is related with the apnea of prematurity. Our first project is a systematic review and a meta-analysis. I would like to give a little explanation to the histopathology of the placenta. Chorioamnionitis means the inflammation of the chorioamnionic membranes, and this is the maternal part of the placenta. And as this inflammation spreads through the chorionic vessels, it causes chorionic vasculitis, and as it reaches the umbilical cord, it causes phenicitis. And this last two is the part of fetal inflammatory response. Intrauterine inflammation is one of the leading causes of preterm deliveries, and several studies has already shown the association between chorioamnionitis and different adverse outcomes of preterm neonates. However, the role of fetal inflammatory response in this equation is still unclear. That's why our aim is to investigate the role of additional fetal inflammatory response with chorioamnionitis. Our population include preterm neonates or very low birth weight neonates, and our exposure group contains neonates with histological chorioamnionitis and fetal inflammatory response, and in the comparison group there are neonates with chorioamnionitis alone. The search was conducted in these 4 databases, and in the end of the selection process we had a pool of 47 eligible articles. Here I have to mention that we collected these eligible articles separately, and we have a smaller pool in this whole 47 articles, in which they use more strict, more homogeneous histological classification. And we ran the analysis both in the whole pool and this smaller pool as well, and I will note if there was any difference between the two analyses. Here is the list of our outcomes. These are the major morbidities of prematurity. One of our primary outcomes is mortality. And as you can see, according to this 16 article with more than 3,000 neonates, we found no significant difference between the exposure and the comparison group. However, we can see a slight tendency towards neonates with fetal inflammatory response. In case of early onset sepsis, which is sepsis occurring within the first 72 hours of life, we found a non-significant elevation of the odds of sepsis in case of the presence of fetal inflammatory response. And we found similar distribution in case of late onset sepsis as well. Necrotizing enterocolitis is one of the most common gastrointestinal emergencies among preterm neonates, and here we found no significant difference between the two groups of neonates. Bronchopulmonary dysplasia is a chronic respiratory morbidity of prematurity, and according to the analysis of the whole pool of articles, we found a non-significant elevation in the odds of BPD among neonates with fetal inflammatory response. And analyzing this smaller, more selected population, we found a significant elevation of BPD in case of neonates with lower gestational age. We managed to analyze several neurological outcomes as well, like intraventricular hemorrhage, and in this case we found a positive association between intraventricular hemorrhage and fetal inflammatory response. However, we could not find this significant association in case of severe intraventricular hemorrhage. We found no significant difference between the two groups in case of periventricular leukomalacia and cerebral palsy. We analyzed one maternal outcome as well, clinical chorioamnitis. That means the maternal fever, uterine tenderness, or full smell vaginal discharge. And in this case, we found a significant elevation of clinical chorioamnitis in the case of neonates with fetal inflammatory response. all in all, the strength of our study that we only use study with confirmed histological chorioamnionitis, and we also have a selected population with more strict, more homogeneous histological classification. But just as important are limitations that in certain articles, the outcomes are based on slightly different criteria. And these outcomes are all multifactorial and highly influenced by different factors such as gestational age or mortality. And we collected only unadjusted data. In conclusion, the presence of fetal inflammatory response is associated with elevated incidence of intraventricular hemorrhage, but it does not accompany by the elevation of severe intraventricular hemorrhage. And among extremely preterm neonates, fetal inflammatory response is associated with the elevated odds of BPD. And chorioamnionitis with fetal inflammatory response is clinically more apparent than chorioamnionitis alone. Our implication is that regular histological examination of the umbilical cord should be considered, and fetal inflammatory response should be part of the sepsis assessment and prognosis evaluation, and should be part of the basic characteristics in the studies. And we met the same problem like other meta-analysis in this topic, in this population, that both unadjusted and adjusted data has its drawback. So the ideal would be a meta-analysis of individual patient data. And one of our most important, of course, is identifying the possible steps between the intrauterine inflammation and neonatal morbidities. Currently, I'm writing the manuscript, and we are planning to finish it by the middle of June. Our second project is a planned protocol of a randomized controlled trial, the effect of additional pre-extubation loading dose of caffeine citrate. One of the most common indications for intubation or reintubation are frequent episodes of apneas. And since the CAP trial, which is caffeine for apnea prematurity trial, there is an evidence that caffeine can decrease continued apnea and associated with shortened duration of ventilation. Clinicians prefer to use non-invasive ventilation initially to avoid mechanical ventilation. However, there are cases when it's inevitable. And in these cases, they try to remove this endotracheal tube as soon as possible because of its complications such as bronchopulmonary dysplasia or reduced lung function. That's why our aim is to investigate a higher level of caffeine citrate in this quite vulnerable period, the peri-extubational period. Our clinical question is, does additional loading dose of caffeine citrate 1 hour before planned extubation reduces extubation failure? Our population will be preterm neonates born before the 32nd gestational week is completed and had been mechanically ventilated for at least 48 hours. And our intervention will be an additional 20 milligram per kilogram loading dose of caffeine citrate before extubation. Our primary outcome is reintubation within the next 48 hours. Our implication is that caffeine can decrease extubation failure and mechanical ventilation day, and thus BPD, and this study can contribute to finding the optimal dosing regimes of caffeine. Here are our eligibility criteria, both inclusion and exclusion criteria, and we managed to conduct a sample size calculation, and we are planning to do an interim analysis as well. This is planned to be a 2-arm study with the intervention of 20 milligram per kilogram caffeine. And beside our primary outcome, we have additional outcomes as well, such as frequency of apneas, heart rate, gastric residuals, or blood pressure. Here is a quick overview of our planned studies and the estimated submission dates. And thank you for your attention. I brought a quote for the prematures. From a tiny spark may burst a mighty flame. Thank you for your attention. And I welcome any question.
First of all, I would like to ask that I have seen that you completed the sample size calculation for your RCT. And what do you think, when will you achieve this amount of patients, and how many centers you are, sorry if I missed the information, how many centers would you like to include in this, this trial?
Thank you for your question. We are planning to include all 3 neonatal intensive care units of Semmelweis University, because this could provide us a kind of homogeneous population because of the protocol of the institutions. And yeah, we are calculating with 50 to 60 patients per year. So it would be for the whole analysis, it could be even 4 years.
My question would be that you mentioned that there are more strict and more homogeneous histological classifications in certain articles, and what did you mean by that?
At the beginning, I introduced you these histological kind of stages of the progression of this inflammation, and there are we selected these certain articles with more strict histological classification in case if they included in the term of fetal inflammatory response both chorionic vasculitis and phoenicitis, because there are articles in which they only defined it as phoenicitis and they didn't further specify whether they included chorionic vasculitis in the phoenicitis group or in the chorioamnionitis group.
My question is regarding to your meta-analysis. As I remember, you choose 28 weeks as a cutoff point in the subgroup analysis. What is the reason behind this? Why did you choose this cutoff point?
Thank you. We choose this because prematurity has different subgroups, and we calculate extremely preterm neonates under 28 weeks from gestation. And these morbidities are highly specific for prematurity, and these morbidities occur more often in these groups under 28 weeks of gestations.
I would like to ask regarding to the randomized control trial, do you plan any stratification on gestational age or not?
Yes, we are planning to do a stratification according to the gestational age and the sex of the neonates. And we were planning to do according to the presence of early onset sepsis and the type of the sedations, but it would elevate the sample size. So we are thinking about go with these two, sex and gestational age.